Bilirubin metabolism and genetic disorders. Heme gets oxidized in the presence of heme oxygenase and NADPH to biliverdin, which in the presence of biliverdin reductase gets oxidized to bilirubin, the hepatocellular transport of bilirubin. The unconjugated bilirubin is bound to albumin and reaches the space of Dis where it gets dissociated, and UCB, which is unconjugated bilirubin, enters the space of Dis. Through the bilirubin transporter, it enters the hepatocyte. And then it binds to GST, which is glutathione S transferase. Then the UCB gets released inside the hepatocyte. It gets conjugated to bilirubin monoglucuronide. In the presence of UDP, glucuronyl transferase, UGT1A1. That further gets converted to bilirubin diglucuronide, which enters the bile through the MRP2 protein, which is the multi-drug resistance associated protein 2. Dubin-Johnson and Rotor syndrome. Both are causes of direct bilirubinemia. Dubin-Johnson is due to MRP2 mutation, but Rotor's, the cause is not known. They're usually asymptomatic, except they could have fatigue. The total bilirubin usually is between 2 and 5. It's never so high. And all other LFTs are normal. The liver biopsy in Dubin-Johnson syndrome shows coarse granular pigment in the centrilobular area, while there is no such pigment in Rotor syndrome and the biopsy is normal. Oral cholecystography in Dubin-Johnson's, the gallbladder is not seen. Well, the gallbladder is seen for Rotor syndrome. No treatment is needed for either of them. Dubin-Johnson is seen mostly in Iranian Jews, 1 in 1,300. Bile acids in both cases are normal. Crigler-Najjar syndrome, indirect bilirubinemia, and Gilbert syndrome. Gilbert's is a benign one. Crigler-Najjar presents in infancy. 1 and 2 are differentiated by the amount of UGT1A1 present. Crigler-Najjar 1 is complete absence of UGT1A1. 2, there is 10% activity available, and with phenobarbital, the bilirubin reduces by 75%. Crigler-Najjar 1, they die early with kernicterus, and liver transplant is curative, and phenobarbital does not work. Gilbert syndrome is a very benign one. There's a mild reduction in UGT1A1 activity. The total bilirubin is usually less than 4, and it can reduce with phenobarbital. Other causes of indirect hyperbilirubinemia are ineffective erythropoiesis, hemolysis, large hematomas, pulmonary infarcts, transfusion of old blood, erythropoietic porphyria, and lead poisoning. Benign recurrent intrahepatic cholestasis, BRIC1, also called Tigstrup or Summerskill and Walsh cholestasis. There are recurrent attacks of pruritus and jaundice. There is malaise with an increase in aminotransferases. There is increased alkaline phosphatase and total bilirubin causing itching and jaundice. There is extensive reflux of conjugated bilirubin into the plasma. It begins in childhood. The child is normal in between episodes. This does not lead to cirrhosis, but the itching can be debilitating. It's due to a mutation in the ATP8B1 gene. which is the same gene as a PFIC1 gene. In BRIC2, there is a mutation of BSEP, which is the bile salt export pump. Intrahepatic cholestasis of pregnancy. Pruritus is seen in pregnancy, mostly in the third trimester, and it increases till delivery. It resolves by 2 to 8 weeks postpartum. It's associated with some genetic mutations. ICP1 is due to FIC1 gene mutation. ICP2 is due to BSEP gene mutation. And ICP3 is due to MDR3 gene mutation. The GGT is normal in 1 and 2, but in 3, the GGT is slightly elevated. There is an increased risk of fetal distress and intrauterine death. The treatment is UDCA until the delivery of the baby. There is a risk for gallstones in the future, cholecystitis, and later cirrhosis. Progressive familial intrahepatic cholestasis, that is PFIC 1, 2, and 3. The difference is somewhat similar to intrahepatic cholestasis of pregnancy, in which the GGT is normal for 1 and 2 and elevated in PFIC3, but it's quite elevated in PFIC3. Increased bilirubin is seen in all three. Increased bile acid is seen in all three. Cholestasis is from infancy in PFIC1, and it's progressive, and the child needs a liver transplant. PFIC1 is due to FIC1 gene mutation. PFIC2, the ABCB2 gene is mutated. PFIC3, ABCB4 gene is mutated. PFIC1, the biopsy shows a bland cholestasis with little inflammation. In 2, the biopsy features of neonatal hepatitis. And in PFIC3, you would understand that the GGT is elevated, so there is some bile ductular proliferation.